this online, and ages since I've used Microsoft Teams for this, so my apologies if things go awry. What I've got at the moment is talk about heavy menstrual bleeding, and it's an overview, and it's something that I come across a lot, and it's something that I hope is useful to share with you all. I have some disclosures to present, and then learning outcomes, because you have to have learning outcomes. But I'm hoping that there will be other bits of information that you'll glean. So my sources of information, really nice guidelines, but also I've used the RCGP Learning Women's Health Toolkit because I thought that was useful. And something that I hope you'll be familiar with, even if you're not familiar with the NICE guidelines. But the NICE guidelines do have some useful things to offer. So, and I'll be using those in my talk. Now, one of the things that is available, and we've developed in conjunction with the cases mentoring team, the online referral form for women with abnormal uterine bleeding. If you can't remember all that you should be doing for these ladies, then there are prompts here apart from anything else. I think it's helpful to have a few sentences about the woman and why she needs to be seen. The other thing is the criteria for referral for abnormal uterine bleeding. So this abnormal uterine bleeding includes the heavy menstrual bleeding. It doesn't include your PMBs. They're still seen on the fast track service, but it's looking at the intermenstrual bleeding, irregular cycles, infrequent cycles, ladies with pain, with or without pain, with their periods. But it also prompts about what treatment have you tried so far, because it's really useful to know what's been successful, what hasn't. And things like tranexamic acid, it's worth initiating along with the non-steroidal anti-inflammatories, and with those are, say, not mefenamic acid. That's recognised as too expensive and too many side effects. But then there's hormonal things, there's the Mirena coil. It's worth us knowing what are the patient's facilities concerns. Is she trying to get pregnant? Is that something that she doesn't, I know that she's past that stage. It's useful to know examination findings, BMI. Not every woman you'll have examined. It won't have been appropriate for that for all of the women, your young girls who've never been sexually active. Investigation results as per the NICE guidelines, which is what I'll be referring to.
Because I guess
you've just gone on mute, Mary. I'm not sure why. I'm unable to unmute you. Sorry.
It might have been a like change of lead or something like that from the previous one. Yeah. Could be yearly or something, couldn't it? Yeah, definitely. Yeah.
I don't think I can unmute you from this end.
How's that? That better?
You're back. You're back.
Right, great.
I'll be quiet again now.
Right, that's fine. I'll come back to my slide and back to the screen presentation. Right, I think I know what to do if that happens again. So I suppose an obvious question is, why focus on heavy menstrual bleeding? Well, it affects a lot of women. 1 in 5 women of reproductive age have problems with heavy bleeding, and 1 in 20 women will be contacting their GP each year with this problem. And it affects their physical, psychological and social health and well-being. And 40% of these women experience anxiety, and 67% suffer with depression. And this seems to be an additional factor. It's a complicating factor, and it may be the initiating factor for their depression. It's a problem. Just really, I suppose, focusing as well on concerns that we have. Women with obesity or unopposed estrogen excess, so those ladies with infrequent periods, with PCOS, they are at risk of endometrial hyperplasia and endometrial cancer. We all know that the number of women who are obese is increasing along with men, but it's the rates of obesity and the endometrial pathology are rising as a consequence. So in tandem, we know that obesity is one of the initiating factors for this. My phone, sorry, telling me that I better mute it, telling me that I should be starting my talk. So there are 2 pathways that the NICE guidelines are helpful with. And one is for the diagnosis and the other is for treatment. And we'll be looking at both of those. And it helps us with where to start. So the patient presents with a history of heavy menstrual bleeding. So history and examination, check a full blood count. The things that support this and things we may be asked to confirm that we are doing, the nice quality standards for heavy menstrual bleeding. People present with symptoms related to heavy menstrual bleeding have a focused history taken that includes the impact on the quality of their life. So this is a relatively new statement and standard. So what is that focused history? Well, it's looking at the nature of the bleeding, its duration, the heaviness.
Sorry, Mary. I don't think we're keeping up on the slides that you're on. I'm not sure if you're...
Right, I'm on focused history at the moment. Let me just come out of this.
Yeah. Oh, it's just changed. It's just jumped onto focused history.
Right, if I could do this as a presenter view, I wonder if that would help, but I can't see how I can do that.
So I'm not sure what the difference is. I don't know.
When you go on share and then go on to, you should have window and a number next to it.
Not a problem. You know, I am.
If your presentation is on that list there, that should be the best way to do it.
Right, of which on, but that's what I did.
Right.
So I'm just looking to see if there's looking to see if there's something there. So I'm just looking to see if there's anything else. If I stop sharing and share again, how about that, and see if that helps?
Give that a go.
So what I've got is basic. Oh, gosh, that's PowerPoint Live. That's too many things. I've got Windows. I can show calendar, documents, and it disappears very quickly.
So when you go on share and you've got a window with a number next to it.
One of one.
And then have you got your presentation as an option there?
No.
Right. If you want to...
I've got Windows 4. I've got Windows 4 options and my presentation. If I click on Windows 4, my presentation is an option.
Yes, if you go on that.
Yep.
And then if you do that slideshow full screen.
Yep.
From current slide. Okay,
yep.
That's perfect. We're on focused history, which is hopefully what you're seeing as well.
Yep. But that's where we'd got to. So whether it's the moving on that seems to be the problem.
Before we didn't have this view, we could just see your overall presentation, but we've now gone back on to be able to see the presentation again. So I think we're back on track.
I think it must have disappeared. I think it must have disappeared because this is what I had before. Lovely. Focus history. We've talked about the nature of bleeding, related symptoms, pain and tiredness, and then the impact on the quality of life. So basic things like, are they soiling? What's happening to their clothes, their bedding? We hear stories about ladies who go out for dinner and the waiters come up to them and said, "Excuse me, madam." They bled on the floor and they bled on the chair. It's very distressing. And this can happen with an episode of flooding, particularly, which has caught them out. How does a teacher leave a classroom in order to go and change a pad because she's flooding? It's those sorts of difficulties that we're looking at. So it's not necessarily the number of days, it's not necessarily the impact on their hemoglobin level, but it's the impact it's having on their life. There are things we need to think about: comorbidities, previous treatment for heavy menstrual bleeding, fertility requirements, and those are reflected in that online referral form as well. So we need to establish the symptoms that may indicate uterine cavity or histological abnormality, so adenomyosis or fibroids. That includes your intermenstrual bleeding, postcoital bleeding, pelvic pain, and that can be independent of periods, but it can be a dysmenorrhea, and sort of pelvic pressure. So we're thinking about endometriosis, fibroid uterus. Investigations, full blood count, that is the primary one. And I suppose the other thing to say is it may need repeating, particularly if you've referred the woman and it's sometime before we see her, and the situation's changed during that time, you might need to repeat that full blood count. I'm just thinking of a lady yesterday that I saw. She had been to clinic in June. She'd had a full blood count in January. She'd had one in November. So the November hemoglobin was 83 grams per litre. January's was 83. We saw it in June. We didn't repeat it. She wanted to see a woman, so she got referred to my clinic yesterday. We repeated it. It's 83. We're clearly, she's not responding to what we're doing. And we need to be trying to keep on top of this. So that may be that even if you have tried to share responsibility for the patient, that things can change. We do need to respond to that. And the patient needs to ask for more help. Now, there are situations where we need to be testing for coagulation disorders, and that's particularly if this is a young woman with family history of coagulation disorders, and it's been a problem since the period started. It may be appropriate for you to offer sexual health screening. Smear tests need to be up to date if one's due, but there's no indication for routine thyroid function tests, routine ferritin, unless there are additional symptoms. So no further examination or investigations needed if the woman has heavy menstrual bleeding with no additional signs or symptoms, no suspected abnormality. You can go for basic treatment. You can get something started, the oral contraceptive pill, as many of you will have been doing. So the basics you don't necessarily need to change. When do we need to think about ultrasound scan? Now, NICE guidelines 2018 were famous for saying thou shalt not request a transvaginal scan unless. So it wasn't to be part of routine. I must admit, I don't think practice has changed, and I'm not complaining. I find it really useful for us. We don't offer treatment to every patient that comes to hysteroscopy. We haven't got those facilities yet. So if we know somebody's got a suggestion of a polyp on scan, we can direct them to a see and treat clinic. So from our point of view, it's helpful. So the women NICE want us to be scanning, include those where you can't actually assess them. And that will happen to many of the ladies who are overweight, significantly overweight. But think as well, if you've got an enlarged uterus on examination, we need to check that it's fibroids. Pelvic mass on examination, again, we need to check what it is. If they've got pressure symptoms, is it big fibroid, significant dysmenorrhea? Are there any chocolate cysts to indicate endometriosis? Now, another statement, they're not in order. This is number 3 statement. I'm not ignoring 2, but I'll come to that later. People with heavy menstrual bleeding have a discussion with the healthcare professional about all their treatment options. And there is help here from the NICE guidelines. And I'll show you that shortly. But we need to be discussing those treatment options. We need to take into account the fertility, what they want, whether they want to keep the uterus, benefits and harms of treatments, clinical considerations as well. You know, what other comorbidities do they have? Size of the uterus. So I think this shared decision-making aid for heavy menstrual bleeding is really helpful. And I think it's preferable to an information sheet that we had ourselves. So I've chosen not to rewrite ours. And I basically go through the options with the patient, give this to them so that they can take it away. I like it because I think it's got good detail in it. So we can monitor, we can offer hormonal treatment, non-hormonal treatment and surgical treatment. And it's easy to go through those. Now, if the patient's got a normal size uterus or they have fibroids that are less than 3 centimetres, then we can consider the Mirena coil. It's often worth thinking about combined oral contraceptive pills, perhaps cyclical oral progestogens. But it's worth sending somebody away with the basics, the tranexamic acids, non-steroidal anti-inflammatory drugs to get them started. Many women don't find they are enough, but it'll help from the outset. Now, when it comes to the Mirena coil, what I like about the shared decision aids is it looks at the options, the benefits, but also possible side effects. So that's something that women can consider. So we know the Mirena coil is effective, but we also know it has some limits, and about 50% of women will have it removed because of side effects. It's worth women knowing that it is going to take several months for the Mirena to have a full impact. And we can see here that bleeding and spotting can be a problem for many of them for a good length of time. And it's worth remembering this when we're talking about it to women. Other hormones, yes, certainly the combined pill has a very good role. if we're going to go down the oral progestogens, and they've only mentioned norethistone here, they've not included medroxyprogesterone acetate, but both of them have a place. We know that norethistone is a bit more effective at stopping bleeding than norethistone, but there's a slightly increased risk of thrombosis, which is perhaps a bit theoretical more than real. What I do want to draw your attention to is the fact that long cycles are definitely better than short cycles. Short cycles are in the BNF. They're awful. They can make bleeding worse. So I'll mention those again in a moment. There is good evidence to suggest that the long course progestogens, and by that it's the day 5 to 26, so the 3 weeks per month, or continuous even. There's evidence that reduces menstrual blood loss, might be less effective than tranexamic acid, but there are not many papers. There's not much data out there. There are no studies of satisfaction or quality of life improvement. But remember, days 5 to 26 or for 21 days, not for 5 or 10. That's really neither use nor ornament. Progestogens in other forms, yes, certainly some people find the Depo-Provera injections helpful. They become amenorrheic. Other people spot every day. So different things for different people, depends on where they are in their life, what they're wanting in the way of forms of contraception, what suits them. So long cycle regimes definitely better than short cycle for reducing menstrual blood loss. Ignore the BNF on this. Online BNF I think is better. Compliance seems better with continuous treatment than cyclical, though, and that's something I've heard from other colleagues. Professor Hilary Critchley in Edinburgh does a lot of work on heavy menstrual bleeding, and this is what she finds in particular. Norethistone is more effective than medroxyprogesterone acetate at reducing menstrual bleeding, so perhaps worth starting with that in the women who you're not worried about being at high risk of thrombosis. The Mirena coil is certainly effective at reducing overall blood loss, better than oral treatment in the long term. But intermenstrual bleeding is less troublesome with a long cycle regime or oral progestogens. So just looking again, tranexamic acid, non-steroidal anti-inflammatory drugs, do throw those in, particularly when you're starting out with treatment. The tranexamic acid can be used 3 or even 4 times a day, and that's on the online BNF. It's not mentioned here. It's not in the paperback versions of the BNF, but it is effective. It says for 4 days each month. I'm not sure where this 4 days or even 5 days has come from, but it's really when that bleeding's heavy and there is no great risk of thrombosis. As far as non-steroidal anti-inflammatories drugs, mefenamic's mentioned here, but think of naproxen instead. Ibuprofen or naproxen, not your mefenamic acid at £18 a pack. When it's pence for the ibuprofen, and fewer side effects with your ibuprofen, and it's as effective, and you can combine that with your tranexamic acid. So when to refer to secondary care? Really, it's when hysteroscopy is indicated, and NICE say persistent intermenstrual bleeding, women at high risk of endometrial pathology, suspected submucosal fibroids, perhaps on the ultrasound scan. And then they can have outpatient hysteroscopy, or if they decline that, they can have it done under general anaesthetic. We find about 90% of the women accept outpatient, but we always have to be prepared to do it as a under general anaesthetic. So your transvaginal scan in your even transabdominal in the young non-sexually active women, useful. And when pain's a significant factor, think of secondary care when there's excessive bleeding and severe anemia. So it's your severe symptoms, submucosal fibroids, larger fibroids as well, because we need to be thinking about other means of treating. And there are new GnRH antagonists, oral preparation instead of your GnRH analogues, which are by injection. So they're new on the market and they seem to be effective, and they're licensed for longer than the analogues. So the second standard was to offer hysteroscopy to patients with suspected fibroids or polyps or endometrial pathology. So that fits in with that particular arm of the pathway. And we need to think as well about women who are at risk of this because they're obese, infrequent periods, family history of Lynch syndrome, and unsuccessful heavy menstrual bleeding treatment. So the patients that they've highlighted at the bottom of this pathway are the ones I've mentioned on the right-hand side in the text box. Just to give you some idea of context about the risk of endometrial abnormalities, it is changing, but this paper was published in 2016, and we can see that the percentage of women with endometrial cancer is low in the younger women, not nil, but low. And certainly endometrial hyperplasia or atypical hyperplasia is much more common. But the risk of cancer basically increases in age. But it's to give you some idea that the risk is low. Now, the idea of Pennant's paper was to say you don't need to be doing endometrial biopsies in these younger women. Actually, what we need to take into account are the risk factors, and that's something that the paper didn't discuss, risk factors for things like obesity and ovulatory cycles. So that's the sort of thing we need to be thinking about. I'll come back to this online form, partly because it's been difficult to get it available to you. We do want it being used. We hope it'll be helpful. It's not written in tablets of stone, so it can be altered if people feel it's unhelpful. But we've based it on the MSK online referral form because people seem to find that helpful. And if you've got associate nurses working with you who are not so familiar with it, or PAs, then this may help them too as to thinking, right, well, where have we got to? Are there other things that we should be doing? What information do I need to provide in the referral? Because sometimes we get really paltry information because little has been done and patient hasn't been offered any treatment. And we're assuming because time factors, I know you're busy, but also are people not sure what to do? And I'm hoping that this will prove helpful in this situation. So those are our learning outcomes. And I probably think it's time for questions at this point. So I think we're reasonably on time.
We've got 3 questions in the chat, Mary.
Right.
Rather than me making an absolute ham of trying to pronounce some of this as the non-clinician in the room, it's probably better if you are able to pop in and just have a look. So we've got
right
one
now.
from Sally,
tell me what I've got
Rachel,
to do.
and Sarah.
How do I join?
You should be able to just see the chat at the top.
Yeah.
If you click on that,
you'll need to go back to the window you were sharing to resume. Oh, got to stop sharing.
Yeah.
Right.
And then if you just pop into the chat at the top.
Go on, tell me what that means.
There's a little button top left of that row on your, so the top right hand side of your screen.
Yep.
On the far left, there's a one that says chat with a little speech bubble.
Yeah, I've clicked
if you click on that, then you should be able to see the chat from.
Right, I've got it. I've just got to read. Sorry. Yeah.
And then at the bottom, we've got 3 queries there together.
Yeah. Is there any role at all for the endometrial biopsy in primary care still? Well, as the person who led on that, yes, is my answer. And I've fallen out with Justin Clark over this a few times because he was the one that doesn't want us doing it. There are advantages and disadvantages. Clearly, if it delays women being referred, just another thought, a patient who is otherwise doesn't have intermenstrual bleeding or postcoital bleeding, but is obese, then I think she is at risk of an endometrial abnormality. It's probably, you're going to be sounding anyway. And I think it's useful to take an endometrial biopsy for everyone's reassurance, particularly if she's going to get some irregular bleeding with a Mirena coil. So I feel that the role is for taking a biopsy at the time of fitting a Mirena coil. You're going to be sounding the uterus. The Pipelle sampler is really good for measuring the cavity length. So I think that, yes, there is, but that's my bias. But I think what we're aiming to do, and the whole purpose of that, was to keep women in primary care and to maintain the management of women with these problems within primary care. Right. Oh, this is a nice question from Rachel Kemp. When gynae specialists, well, I think you all probably can see it, can't you, if you're on chat too. Can we assume that the risk has been assessed? I think one has to assume not, because your approach may be perhaps more holistic than has been than was considered before. I think the person will have considered the risks, but have felt tied by the patient's needs. But I think if you're then going to continue that prescribing, then that responsibility needs to be yours. And if you feel that it's inappropriate, you may have more information than we had or took notice of. So I would assume that, I think that you have to assume that they may not have fully understood the risks involved. And if you're taking clinical responsibility for prescribing the combined pill, and you feel that there isn't anything else that has been, that there are other reasons for it, then I think it's reasonable to have that conversation with the patient again and just say, well, because these things aren't often completely black and white. And I think it's worth revisiting. Right. Do we need to be referring young women with HMB who are obese, e.g. those under 40? I think it's not just because they're obese. It depends on other factors. And if they've got heavy bleeding, then I think they're the group of women where it's worth probably taking that endometrial biopsy. So if they don't have other problems, bleeding between the periods and postcoital bleeding, then I think you don't need to be referring them on, particularly if you're offering them a Mirena coil. But some of those young women may want to get pregnant. But I think the conversation then is about the weight, appropriateness for fertility and those sorts of things. Right. Caroline Rogers' comment, if bleeding isn't controlled with IUS or the combined pill, do you still give additional northisterone? I do. Thinking about some of the ladies I put Mirena coils into, these are some of the postmenopausal ladies who are bleeding heavily. I think it's really helpful, and I think it works. Couldn't give you evidence for this, to start them off, particularly if they say they've started with northisterone or medroxyprogesterone already, then, and I'm worried about the coil being passed with a blood clot, then I may well give them continue with your current medication for 3 months and hope that that will help keep the coil in place. So particularly, I'm just thinking of a lady who's come back today. We put her Mirena coil in for management of endometrial hyperplasia. Probably worth giving her something in addition to tide her over to help with that. Right. Archie Bansel's asked, if we use the combined oral contraceptive pill, should we always tricycle to reduce number of bleeds? Depends on how bad the hemoglobin is. Depends on, I think that's a sort of a discussion to have with the patient. So I don't think that you should always, because they may find that it suits them well enough with a 3-week on and a week off. But I think it's certainly something that particularly if those periods are painful, that's, your endometriosis ladies, I think that's where it's particularly helpful. Right. Right, Liam Lees, I'm not sure I've got I think I've understood the question. So if not fully aware of the risks, they may know that you may know something more about the patient than has been made aware to the clinician in hospital. They shouldn't be recommending it, but I suppose we don't always get things right, I would say. So if you're uncomfortable about that, and I've certainly been challenged by GPs, they've written back to me and said, I'm not happy with this because of so and so. So I think we're all clinicians, we're all adults, we all make mistakes, and you may feel differently about some of the risks, or there may be a different understanding of the risks. If we think about patients who are on apixaban or indoxaban, one of the other DOACs, then giving them something that increases their risk of thrombosis may be okay in that context. That may not be understood by everybody. People worry more about giving tranexamic acid in primary care than perhaps secondary care. There are risks of thrombosis with the progestogens, but it's how much of a risk and what the balance is. So it's not just with the combined oral contraceptive pill. And I'm not sure about the bit I didn't understand, or GP shouldn't take on prescription. I think these things are negotiable. Right. Yeah. So Rachel's comment, I think, in response to my women under 40. Yeah, I think the PCOS women, if they're having very infrequent periods, that's the other comment to make, is to make sure that they're having a sufficient turnover of their endometrium each year, 3-4 times a year, with a course of progestogens. Oh, right, here we are. That's the next question. Yes. Is it true women need to have 2 to 3 periods a year to keep endometrium healthy? I'd say 3 or 4. Even if taking due to awful heavy menstrual bleeding. So it's the PCOS women. If they're taking hormones, estrogens, progestogens, they've got the balance. The same applies to your HRTs. It's that balance of estrogen and progestogen. If you increase their estrogen, we need to make sure that they've got sufficient progestogen to balance that. So I think we're there with that.
I think, to be honest, that is the end of the session, because we've got a 5-minute gap between now and the one at 22. So
people will need that.
Thank you very much. That was really great. Thanks.
Well, if you do get any more questions, happy to respond.
Perfect. Thank you very much.
Good. Quite a sizable audience now, no? Lovely. Okay. Hope that was fine. Bye for now, and hope we can meet in person at some stage rather than just online.